Well, hey there, and thank you so much for joining me on my channel, JC Lee MD. For those of you who haven't met me yet, and let's be real, this is a relatively new channel, so that's probably a lot of you. I am a Canadian-trained and American Board of Psychiatry and Neurology vetted child and adolescent psychiatrist, and I honestly have the best job in the world. My goal with this channel is really to deliver that news you can use when it comes to mental health, psychotherapy, book reviews, medications, and all of that jazz. Well, today I want to talk a little bit about the selective serotonin reuptake inhibitors, or SSRIs. Many of you probably have a good friend or a coach or an aunt who is on one of these. They're widely prescribed in the realm of psychiatry, and they're often favored in comparison to first and second generation antidepressants and anti-anxiety medications like tricyclic antidepressants and monoamine oxidase inhibitors because of their very favorable risk-benefit ratio. SSRIs have been around since the 90s. Essentially, the first one on the market was fluoxetine, or Prozac, culminating in a more recent development, but still also 2 decades old, of escitalopram, or Lexapro. These are medications that work to basically inhibit the recycling of serotonin in the synaptic cleft to basically allow the serotonin to influence the brain, leading to synaptic plasticity and growth of different axonal connections, etc., throughout the brain and body. Presumably, in the past, there was this idea of a neurochemical imbalance, the so-called monoamine hypothesis of depression, wherein which people who were depressed were presumed to have lower tonic activity of monoamine neurotransmitters like serotonin, dopamine, and norepinephrine. The bottom line is, in recent days, that idea has really become a moot point, and modern imaging studies have not found this so-called serotonergic deficiency. But that being said, the SSRIs seem to work, irrespective of whether we've got the mechanism of action or the actual therapeutic element correct. A lot of times people will come to me as a prescriber and say, I've tried Prozac, I've tried Lexapro, I've tried Zoloft, nothing really works. And when I ask them how long they've been on these medications for at a time, they'll usually say something like 2-3 days, maybe 5 days. Essentially because the side effects were so cumbersome that they had to stop it. They just couldn't tolerate the nausea, they couldn't tolerate the sort of sleepiness, drowsiness, and couldn't really get over that hump of the initial 7 to 10 days of nuisancey side effects. These medications really need to be titrated to a therapeutic dose. And each medication has a typical dose range within which the majority of people will have a really beneficial effect, in this case for depression. For instance, Prozac or fluoxetine typically is started at around 5 or 10 milligrams, depending on if you're treating children or otherwise, and then titrated to between 20 to 80 milligrams at its max. And 90% of people will respond to a dose somewhere in that range of 20 to 80. The problem is we never really know when we see a person, first off, what part of that range the person might respond to. Now, SSRIs have come under fire in recent years for a number of reasons. The FDA and Health Canada continue to have a black box warning for enhanced suicidal ideation in young people under the age of 25 who are on these antidepressant medications. And this black box warning comes from an unfortunate research study by Hamad and colleagues in 2004 that was published in Archives of General Psychiatry. Very high, top tier impact journal. And essentially what the authors found was that depressed young people who were given antidepressants also endorsed a lot more suicidal ideation. And in the aftermath of that study, the number of prescriptions of antidepressants in young people went down, and the number of actual completed suicides went up. And so this tells us that correlation is not causation. That is to say, depressed young people tend to have suicidal thoughts. Depressed young people tend to be given antidepressant medications, but it does not follow that the antidepressant medications cause the suicidal ideation and thoughts themselves. So a lot of parents, especially the well-informed Californian types, will come to me and ask about this black box warning, and I think it's really important to couch that in the context of the research study and to really appreciate that correlation does not imply causation at baseline. Now, if you look at the laundry list of potential adverse events of these medications, you will probably fall asleep reading all the millions of different lines here and there, the 0.01% of neurasthenia or, any kind of dystonia or tremor. But the main majority of side effects that I talk about with my patients are only a few. The only side effect of selective serotonin reuptake inhibitors that can actually really kill you, in my opinion, is something called serotonin syndrome. This is when we push the serotonergic activity in your body up too high, too fast, and you end up having a high fever, feeling very hot, flushed, sweaty, having massive turbo diarrhea to the point that your muscles become twitchy, and ultimately you have a seizure, coma, and death. Not what I want to happen to any of my patients, and certainly has never happened to any of the thousands of people that I prescribe these medications to. The only people that I've seen this happen to in my training and residency in Toronto were 20-year-olds who were partying with cocaine and ecstasy, obviously serotonergic and dopaminergic agents in their own right, or the odd 65-year-old with breast cancer, lung cancer, and a brain tumor to boot. The average, otherwise healthy, medically speaking, individual is highly unlikely to have serotonin syndrome, but I always counsel people to be mindful that a high fever, feeling hot, flushed, sweaty, massive diarrhea, and twitchy muscles on an SSRI warrants a visit to the emergency department or at least urgent care. Everything else really will come and go except for one final side effect that I'll talk about last. Things like tension type headaches, often very mild, self-limiting. If you're the type of person who tends to take medication for your headaches, it's probably better to default to acetaminophen or Tylenol rather than ibuprofen or Advil, and that's because ibuprofen and other NSAIDs of that nature basically are anti-inflammatories that inhibit the action of platelets. Platelets are those blood cells that when you cut yourself by accident, essentially they plug up the sort of hole in the skin and create a platelet plug to staunch the bleeding. Now, things like aspirin and Advil will prevent that platelet clot from forming, as do things like SSRIs, like Prozac and Lexapro. And so the two in combination are highly unlikely to give you a very consequential bleed unless you're planning on having a cesarean section or open heart surgery, but better safe than sorry. In reality, if you happen to take an Advil on an SSRI, you'll probably just get some bloody gums when you brush your teeth or some more easy bruising for that day, but better safe than sorry. So headaches are definitely one that people complain about a lot. Another aspect is those GI symptoms. So we have a ton of serotonergic receptors in our gut that respond to Lexapro, Prozac, and the others. And as a result, often people will find that they have some nausea or upset stomach. Very rarely have I seen people actually vomit or hurl while they're on SSRIs, but depending on your sensitivity and other factors, that is a potential outcome. The reality is, once your receptors are attuned to the extra serotonergic tone, once they get used to it over about 7 to 10 days, these effects will totally go away. Some people find, if they are more anxious in temperament, that when they start an SSRI, they might find their heart fluttering a little bit, like, is this a panic attack? Am I feeling anxious about something? No, it's just the SSRI. Some people also find that their energy changes in the short run such that they're more fatigued. And we see this with certain SSRIs over others, but all of that will ultimately evaporate by about 7 to 10 days or 2 weeks tops, as long as we're on the same dose. The only side effect that doesn't tend to come and go in about 80% of people, if it shows up, it'll stick around, are sexual side effects. So for guys, that's, lower libido, difficulty with erections, and for some people, delayed ejaculation, which some guys really do like for obvious reasons. That being said, for women, lower libido is there, difficulty with lubrication, and delayed or absent orgasm. And this all happens because as we block the serotonergic receptors in the brain, which is what we want to do to get that antidepressant effect, we will also likely block some of the receptors in the spine, which are responsible for our sexual response. Now, sexual dysfunction on SSRIs really only happens when you're on that SSRI at that dose. And so there are many things that your prescriber can sort of run through as options for intervention. For instance, sometimes simply lowering the dose can salvage the beneficial antidepressant effect, but also recuperate sexual functioning. Other times, you might elect to switch one SSRI out for another because not all SSRIs have the same effect in the same person. We just don't know which one is more likely to have this effect until we actually try it and compare in the same individual. And alternatives to that would, of course, be to add in a different medication to reverse that serotonergic blockade or to address or ameliorate it in the spine. These would be things like Wellbutrin or bupropion or mirtazapine or Remeron, or in some cases, just frank Viagra and Cialis. I think it's really important to be aware of the expectations of timeline and recovery. When people start an SSRI, it typically takes about 4 to 6 weeks to see the full beneficial effect in the case of depression. But within 2 weeks of starting an antidepressant medication, you will often see 66% or 2/3 of that eventual 4 to 6 week benefit at the end of those first 2 weeks. So that means we do not start a medication at a very low dose and wait for 4 to 6 weeks. We would typically start at a starting dose and about a week or two thereafter consider titrating up and so on and so forth until we reach the maximum dose up to and including the same, and we actually see a very substantial or notable effect. Typically speaking, in those first 2 weeks, other than adjusting to the side effects, most people will find some relief in terms of their neurovegetative or bodily symptoms of depression. These would be things like, not really getting that restful sleep, tossing and turning, maybe your appetite is a bit wonky. These bodily symptoms of depression tend to come back online first, followed by the more cognitive and emotional aspects of depression, the sort of self-critical thinking, the nihilism, and just the pessimism that permeates so much of our lives when we're depressed. And so if people are not aware that there is this time course of action for resolution of symptoms, sometimes they'll just say like, hey doc, this isn't working. And it's like, it's only been 3 days. The reality is many people can benefit from SSRIs. There's been a lot of back and forth, bad press and controversy. Do they work? Do they not? Are they just like placebo, etc.? And what I typically say is ultimately only you and your provider can come to that conclusion to try an SSRI for depression. Your chances are pretty high of getting a good shot and a good recovery outcome in about 60% of the time if you've never had a medication trial before. With a second and a third trial, your chances rapidly diminish, and in those cases, often it's important to have psychotherapy or other kinds of lifestyle interventions on board. Again, as far as I'm concerned, as a Pisces, as a Chinese Canadian, everything is everything. And when we are depressed, it's really important to do our best to throw everything and the baby in the bath water, so to speak, at it to see what sticks.